Congratulations on making it to the end of this patient simulation. We hope this has been a useful educational experience that you can apply to future patients. As a final step, let's briefly review some of the fundamentals of tuberculosis arthritis. Let's start with the stages of TB arthritis. TB arthritis manifests in 5 distinctive stages. Stage 1 is termed the synovitis stage, characterized by soft tissue swelling. There may be localized osteoporosis but no visible bone lesions. If treated with anti-tuberculous therapy, the prognosis is excellent. Without treatment, patients often transition to stage 2, marked by early arthritis with marginal erosions of the bone, leading to mild stiffness post-treatment. As the patient advances into stage 3, there is more severe arthritis, subperitoneal cysts, loss of joint space. Treatment ends with a fair amount of loss of motion. Stage 4 is characterized by more severe joint destruction, and ultimately, no motion in joints after treatment. Finally, stage 5 is characterized by ankylosis of the joint. Although musculoskeletal TB is not common, occurring in only 1% to 3% of extrapulmonary TB cases, it is essential to recognize its potential impact. Key areas for TB arthritis include the spine, hip, and knee. TB spondylitis in adults represents a reactivation disease, spreading and surrounding the Batson's plexus from intrathoracic nodes. This condition typically begins in the anterior part of the vertebral body, progressing to the intervertebral disc, leading to narrowing of the disc area, loss of vertebral end plate cortex, vertebral collapse, anterior wedging, subluxation deformity, and paraspinal abscesses. The following table categorizes tuberculosis and rheumatic diseases into 4 distinct categories. Our first category is direct musculoskeletal involvement of Mycobacterium tuberculosis. This involves direct infection of the musculoskeletal system by the TB bacillus, leading to conditions such as spondylitis, septic arthritis, osteomyelitis, myositis, subcutaneous abscesses, and tenosynovitis. These conditions represent the direct pathogenic action of Mycobacterium tuberculosis on our musculoskeletal tissues. The second category is M. Tuberculosis infection during rheumatic diseases. Here, the risk of TB infection increases with the use of immunosuppressive agents. This risk is particularly notable in patients with rheumatoid arthritis, being treated with all TNF-alpha inhibitors, such as infliximab, etanercept, and adalimumab. In these cases, the immunosuppression caused by these drugs increases the susceptibility to TB infection. Continuing with our categorization, our third category, drug-induced syndromes, encompasses the side effects that occur due to medications used to treat tuberculosis. This includes conditions like gout, which can be induced by pyrazinamide, and drug-induced lupus, a potential side effect of isoniazid and rifamycins. Rifamycins can also lead to tenosynovitis and uveitis. Another noteworthy syndrome is tendinopathy, which can be induced by fluoroquinolones. These instances demonstrate the need for vigilance when prescribing these medications, as these side effects can significantly affect a patient's quality of life and adherence to treatment. Let's now look at reactive immunologic phenomena. This category includes conditions that are reactive responses to the body's immune system fighting off the Mycobacterium tuberculosis infection. These include reactive arthritis, erythema nodosum, erythema induratum, and A-type amyloidosis. Uveitis also falls under this category. It's crucial to understand that these are not direct effects of the tuberculosis bacteria itself, but rather, they are consequences of the body's immune response to the infection. Another major component of musculoskeletal TB is osteomyelitis, which accounts for 20% of cases. This condition usually presents with cold abscesses, draining sinus tracts, or septic arthritis. TB osteomyelitis can affect both adults and children, but manifests differently in each group. In septic arthritis, joints manifest with pain, swelling, or draining sinuses. When septic arthritis appears on tophaceous gout, SLE or RA, the symptoms include proliferative synovitis with minimal signs of inflammation, perirticular abscesses, draining sinuses, and a lack of response to steroids. Let's turn our attention now to the diagnostic images that will illuminate these complex relationships. On the screen, you will see 2 X-ray images that exemplify the typical manifestations of tuberculosis in the spine, also known as Pott's disease or tuberculous spondylitis. Firstly, let's examine Figure 1. This is a sagittal T1 weighted image of the thoracic spine, demonstrating tuberculous spondylitis involving the T8-T10 vertebrae. Key features to note here are the loss of vertebral body height at T9-T10 and the clear enhancement of the end plates. These are classical radiological signs of tuberculous spondylitis. Moving on to Figure 2, this plain radiograph presents a case of Pott's disease affecting the T8-T9 vertebrae. The collapse of the vertebral bodies, the loss of height, the disc space narrowing, and the bone erosion are clearly noticeable. Additionally, you'll notice the demineralization and loss of definition of the end plates, signs indicative of advanced disease. These images offer a profound, visual insight into the destructive potential of Mycobacterium tuberculosis on the spine. Moving forward, we continue our exploration with Figure 3 and Figure 4, which showcase two more manifestations of tuberculosis within the musculoskeletal system. Figure 3 is an image demonstrating septic arthritis caused by Mycobacterium tuberculosis. This image serves as a vivid reminder of the direct invasive capability of Mycobacterium tuberculosis, extending its effects beyond pulmonary tissue to other systems such as the joints. Next, we have Figure 4, which presents a unique example of cold subcutaneous abscesses caused by M. tuberculosis in a patient with a concurrent psoas muscle abscess. Note the characteristic presentation of these abscesses, which is not uncommon in the context of a disseminated TB infection. The co-occurrence with a psoas abscess highlights the aggressive nature of this pathogen. The treatment for musculoskeletal TB predominantly involves chemotherapy and is often successful due to lower bacterial counts in osteoarticular lesions compared to pulmonary lesions. This approach is supplemented with a 6 to 9 month program of antibiotics, reduced to 4 to 7 months depending on the patient's condition. In some cases, patients might need surgery for associated neurologic deficits, arthroplasty, or a total joint replacement. Testing for TB involves commercial nucleic amplification assays like the Amplicor MTB test, the Cobas Amplicor MTB test, and the Enhanced Amplified Mycobacterium TB Direct test, among others. However, these methods, including PCR, may identify both living and dead bacilli, potentially resulting in positive results even after successful treatment. Fortunately, nucleic amplification assays have improved and now offer rapid and sensitive detection in clinical settings. The use of splints should be limited to short periods to relieve acute symptoms and prevent further deformities. Surgeries are recommended for patients who haven't responded to chemotherapy and those who have severe cartilage destruction, joint deformity, large abscesses, or are dealing with multiple resistance or atypical mycobacteria. The radiologic manifestations of TB septic arthritis include a triad of juxta-articular osteoporosis, gradual joint space narrowing, and peripheral osseous erosions, known as Pfemmister's triad. TB septic arthritis can also be associated with myositis, osteomyelitis, and deep fascia infection, presenting as abscesses, while muscle involvement spreads contagiously from bony lesions. The diagnosis of musculoskeletal manifestations of TB is typically done through the aspiration of joint fluid, periarticular abscesses, or biopsies of bone, synovium, or tendon sheaths, followed by histologic and microbiologic assessments. Here is a specific case involving TB arthritis titled the Pfemmister triad. Our first case involves a 25-year-old man who presented with a painful, swollen left knee joint. His symptoms were insidious and progressive, partially relieved with analgesics, but were accompanied by weight loss and a low-grade fever. Initial investigation results were unremarkable, but an X-ray of the knee showed periarticular osteopenia, multiple marginal erosions, and reduced joint space. High-resolution CT of his chest showed miliary modeling, pointing to an active pulmonary infection. Ultimately, a synovial biopsy revealed granulomas and acid-fast bacilli, confirming tubercular arthritis. Chronic monoarthritis may present similarly and could be caused by spondyloarthropathy, chronic gouty arthritis, or osteosarcoma. However, there are unique features that differentiate these conditions from tuberculous arthropathy, which can be recalled using the Pfemmister triad. Named after the orthopedic surgeon Dallas Burton Pfemmister, this triad consists of juxta-articular osteopenia or osteoporosis, peripheral osseous erosions, and gradual narrowing of joint spaces, classical features of tuberculous arthropathy. Continuing our discussion, let's turn to Figure 5, which provides further insight into the direct effects of Mycobacterium tuberculosis on our musculoskeletal system. This image shows evidence of lytic bone destruction in the distal femur in the patient with septic arthritis we discussed earlier in Figure 3. Lytic bone lesions like this one are a clear indicator of the severe and destructive potential of M. tuberculosis. These are not just simple infections, but rather insidious processes that can profoundly alter the bone structure and function, causing significant morbidity if not promptly recognized and treated. We will now look at a report of 2 cases of tuberculosis of the ankle by Shams et al. From the Journal of Foot and Ankle Surgery 2009. Case 1 is a 53-year-old Indian male with diabetes mellitus, who presented with a swollen and painful left ankle. The patient initially had an ankle fracture 8 months prior, which was treated conservatively, with no surgical repair. He was dependent on a walker for mobility. The patient's pain and swelling worsened progressively over the 2 months leading up to his visit to the emergency room. A notable finding was purulent drainage from an ankle ulcer. On examination, the patient was afebrile. He had a 3 mm ulcer near the left medial malleolus. Laboratory findings showed a white blood cell count of 13,000 cells per cubic millimeter and a platelet count of 458,000. Chest radiograph was normal. Ankle radiographs showed bony erosions. Swab specimens from the ulcer revealed no bacteria. He was administered empiric antibiotic therapy and operated on to stabilize his ankle. Intraoperative bone specimens showed few white blood cells, without organisms seen. Pathology showed both necrotizing and non-necrotizing granulomas. Figure 1 is an anteroposterior radiographic view of the affected ankle joint. This striking image showing significant bone erosions, narrowing of the joint space, and complete destruction of the tibial plafond. These findings corroborate our clinical suspicion of tuberculous arthritis, as they represent the typical radiological changes seen in advanced stages of this condition. Note that the destruction of the tibial plafond in particular is an ominous sign, suggesting a deeply invasive infection that has significantly affected joint structure. Infectious disease was consulted. It was discovered that the patient had not been tested for tuberculosis, TB, using the PPD test. Infectious disease felt patient likely had TB of the bone and joint. An empiric anti-tuberculous treatment regimen was initiated, along with multiple antibiotics pending culture results. The patient was discharged under the continued care of infectious diseases and a podiatric surgeon. Over the next 2 months, arthrodesis surgery was performed to alleviate pain and restore stability. The patient successfully completed the treatment regimen and remained asymptomatic, showing no signs of recurrent infection. The next patient is a 45-year-old Hispanic female. She reported a swollen and painful left ankle. Her pain had originated 3 years prior due to a sprained ankle. She developed an ulcer 3 months after the initial injury. The pain and swelling reoccurred, and immediate treatment and a surgical procedure were conducted. She had been previously diagnosed with rheumatoid arthritis and had been treated with steroids. 2 weeks before coming to the emergency room, her ankle pain and swelling returned and did not respond to oral antibiotics. On examination, she was febrile and had a 3 cm ulcer on the left medial malleolus, accompanied by edema and fluctuance. Pedal pulses were palpable, and lower extremity sensory motor function was intact. Laboratory tests showed a white blood cell (WBC) count of 5,900 cells per cubic millimeter. We consulted infectious diseases ID. Initially, the patient had no known exposure to tuberculosis and refused PPD testing. However, when she agreed to the testing, it revealed induration of 15 mm, indicating a positive result. Surgery and drainage of the septic joint were performed, revealing a caseating material described as white cottage cheese. Figure 8 shows a coronal CT scan of the left ankle, revealing particular soft tissue swelling with effusion, narrowing of the joint space, and areas of extensive bone destruction, especially in the medial aspect of the distal tibia and the talar dome. Figure 9 presents a frontal CT scan of the left ankle, displaying soft tissue swelling, bone erosions, and cortical destruction. The patient was administered empiric anti-tuberculous treatment using rifampin, isoniazid, pyrazinamide, and ethambutol. and was discharged home on directly observed therapy and supervised by the Department of Health. She had outpatient visits with a rheumatologist for further treatment. The treatment was successfully completed, and she remained asymptomatic during the follow-up period, demonstrating. As discussed in the article by Shams et al., certain factors can suggest the possibility of TB. These include the patient's geographical origins, the chronic nature of symptoms, and any underlying conditions that suppress the immune system. Delays in TB diagnosis can occur because TB can mimic other diseases due to its wide range of symptoms. For TB small joint arthritis, the general lack of awareness, early radiographic findings, constitutional or pulmonary involvement, and the gradual onset of symptoms can further delay the diagnosis. A high degree of suspicion is essential for early detection. In the progression of tuberculosis, we encounter several immunological reactions. Tuberculosis is associated with several other conditions, including erythema nodosum, erythema induratum, reactive arthritis, and amyloidosis. Another associated condition is Ponsets disease, which presents as aseptic inflammatory polyarthritis affecting the knees, ankles, and elbows. Now that we have the primary strategy for treating drug-induced lupus is to withdraw the drug believed to be causing the symptoms. It has also been observed that patients with immunodeficiency virus infection, who receive high doses of rifamycins during antimycobacterial therapy, can develop a reversible syndrome of arthritis, arthralgia. Fluoroquinolones, used to treat pulmonary TB, have been associated with arthropathy or tendinopathy, which generally resolve within days or weeks after stopping the fluoroquinolones. Additionally, fluoroquinolones have been linked to tendinitis and tendon rupture, particularly in patients aged 50 years and older, those with renal diseases, renal transplant recipients, or those undergoing concurrent corticosteroid therapy. The use of pyrazinamide is associated with hyperuricemia and gout. Patients with systemic lupus erythematosus, SLE, who are diagnosed with TB, often require immunosuppressive therapy. In patients with rheumatic diseases, the use of TNF-alpha inhibitors, etanercept, infliximab, and adalimumab, has led to the discovery of TB due to reactivation of latent TB infection. Paradoxically, some patients who develop TB as a result of infliximab and etanercept therapy experience worsening symptoms associated with drug-induced lupus syndromes. The BCG vaccine, derived from strains of Mycobacterium bovis, is administered to children worldwide with generally tolerable side effects such as local inflammation, abscesses, lymphadenitis, and estitis. Topical BCG immunotherapy can be used to treat superficial bladder cancer. Antimycobacterial therapy is needed for treating localized or disseminated BCG infection, but pyrazinamide is not recommended for disseminated BCG infections. The BCG vaccination can affect a PPD test, with influencing factors including the interval between vaccination and TST, as well as the age at which the patient was vaccinated. Please continue. The ID specialist will be available for questions now.